You are standing in the casualty ward. The fluorescent lights overhead are humming that, slightly maddening, relentless hum.
We saw that hum very right.
And right in front of you is a 54-year-old man. He is sweating profusely. His skin is pale, clammy, and he's been clutching the center of his chest for the last 40 minutes.
So the clinical anxiety in that room is just palpable?
Oh, absolutely palpable. So a nurse briskly walks up, hands you a pink sheet of paper covered in 12 leads of squiggly black lines, and asks, "Doctor, is it a myocardial infarction?"
And that is the moment of truth, isn't it?
It really is. You glance down, and sure enough, the machine has spit out an automated diagnosis printed cleanly at the top of the page. It reads something alarming.
Right.
But here is the real, terrifying question for you, listening to us right now. In that high-stakes moment, do you actually trust that machine? Or do you possess the capability to trust yourself?
That scenario is basically the ultimate midnight crucible, because in that exact moment, the cognitive temptation to simply look at the machine summary is, well, it's overwhelming.
It's the easy way out.
Exactly. Or, equally dangerous, the temptation is to frantically scan the paper for one specific terrifying pattern.
Like ST elevation.
Right, like ST elevation, while ignoring literally everything else. It is human nature to hunt for the pattern we fear the most when we are under pressure. But that is exactly how lethal diagnoses slip through the cracks.
Pattern hunting. I mean, it's the default setting for anyone who feels rushed or unsure on duty.
Absolutely.
But the goal of our deep dive today is to fundamentally break that habit. We are going to completely decode the language of the electrocardiogram, the ECG.
And we are doing this in 6 structured parts today.
Yes, exactly 6 parts. We are moving away from that frantic 2.0 AM pattern hunting and building a bulletproof, systematic approach.
Which is the only way to do it safely.
I completely agree. Think of it like learning a new language. If you just memorize a few emergency phrases, that is pattern recognition.
Just survival phrases.
Exactly. But if you actually learn the alphabet, the syntax, and the grammar, which is the electrical flow of the myocardium, the heart will literally start speaking to you in full, complex sentences.
And that grammatical approach is the only way to safeguard your patients. A rigid system never fails you, whereas pattern hunting will eventually blind you to something subtle but fatal.
Because the machines aren't perfect, are they?
Not at all.
Yeah.
The algorithms powering those machine reports are notoriously flawed. They miss what they were never programmed to doubt.
Right.
They completely lack clinical context. I mean, they do not know the patient is sweating or clutching their chest. They only process voltage and time.
I want to challenge that slightly, though. Some people listening might argue that, artificial intelligence and machine algorithms are getting better every single year.
Sure, they are improving.
So why shouldn't we rely on a computer that calculates milliseconds perfectly?
Because the computer calculates the millisecond of the wave it thinks it sees.
That's a huge distinction.
It is. If a patient is shivering, creating a baseline artifact, the machine might interpret that as atrial fibrillation.
Wow, just from shivering.
Yes. Or, if a lead sticker is placed even 1 inch too high on the chest wall, the machine might diagnose a massive heart attack that simply does not exist.
So it's a tool, not a doctor.
Exactly. The machine is a tool for measurement, not a substitute for clinical interpretation. And we will prove that as we go through all 6 parts today.
Right. We are going to keep our 54-year-old man from the casualty ward in the back of our minds, and we will apply this systematic approach directly to his tracing to see what the machine might be missing.
Sounds like a perfect plan. Let's start with the basics.
Let's do it. We will take a brief pause here, and then we will dive straight into part 1.
Ready when you are.
All right. Welcome to part 1, the foundation.
The alphabet of our new language.
Exactly. The leads, the paper, the waves, the rate, the rhythm, and the axis. Everything begins with understanding how this century-old technology actually sees the human heart.
And it is entirely an exercise in applied geometry. Every single interpretation you make is governed by one absolute, unbreakable physiological principle.
The deflection rule.
Yes, the deflection rule. If you do not internalize this rule, the squiggles mean absolutely nothing.
Okay, so break down the exact physics of this for us. Why does the ink go up, and why does it go down?
It all comes down to cellular depolarization. When the heart muscle prepares to contract, a wave of positive electrical charge sweeps across the cells.
Okay, a positive wave.
Right. And the ECG electrodes placed on the patient's skin are essentially voltage detectors. If that wave of positive depolarization is moving directly toward an exploring electrode, the machine writes a positive or upward deflection on the paper.
It goes up. Got it.
Yes. Conversely, if that wave of depolarization is moving away from the electrode, it writes a negative or downward deflection.
And that is the entire secret.
That is it. Every single wave is simply the machine telling you the directional flow of electricity at that exact millisecond.
Let me try to visualize that. It is like holding a camera with a motion sensor.
I like that analogy.
Right, so if a runner is sprinting right at my lens, the sensor reads positive. If they pass me and run away, showing me their back, the sensor reads negative.
Spot on.
But what if they run exactly perpendicular to me, like crossing my field of vision from left to right?
That is a brilliant visualization. If they run perfectly perpendicular, you get what we call an isoelectric biphasic wave.
Biphasic meaning two phases.
Exactly. It goes up a little and down a little, right around the baseline. It means the electricity is passing exactly sideways to that specific camera.
Ah, that makes so much sense.
And to capture all these angles, the standard 12-lead ECG is essentially 12 different cameras positioned in very specific anatomical locations around one three-dimensional heart.
Let us map those 12 cameras for the listener.
Yeah.
Because they are not placed randomly. We have two distinct sets of views, right?
Correct. The frontal plane and the horizontal plane.
Let's start with the frontal plane.
First, we have the 6-limb leads. Imagine a flat circle drawn directly on the patient's chest, like a clock face. These leads look at the heart from the top, bottom, left, and right.
And these are the ones connected to the arms and legs.
Yes. You have the original bipolar leads, which compare the electrical potential between two limbs. That's lead I, lead 2, and lead 3.
Okay, and the other three?
Then you have the augmented unipolar leads, AVR, AVL, and AVF. Each of these looks from one specific limb, the right arm, the left arm, or the left foot, directly toward the center of the heart.
So those 6 give us the vertical and lateral borders. But the heart is three-dimensional, right? It has depth.
It absolutely has depth.
It sits inside the chest cavity, pointing forward and down. That is where the chest leads come in.
Precisely. The chest leads, or precordial leads, sweep across the horizontal plane. Leads V1 through V6 physically wrap around the front and left side of the rib cage.
And here is where operator error becomes incredibly dangerous, doesn't it?
Oh, incredibly dangerous. The exact anatomical placement of these stickers is absolutely critical. You do not just eyeball it.
You actually have to feel for the ribs.
You must find the precise intercostal spaces. For instance, V4 must go in the 5th intercostal space at the midclavicular line.
Okay, and the others?
Once V4 is anchored, V3, V5, and V6 naturally wrap around the curvature of the chest. V1 and V2 must sit at the 4th intercostal space on the right and left sternal borders.
I want to pause right there, actually.
Yeah?
Because this is where the theory hits the messy reality of the casualty ward.
It always does.
The patient is sweating, maybe there's chest hair, everyone is rushing. What actually happens if the nurse or the technician places those V1 and V2 electrodes just 1 or 2 intercostal spaces too high?
It creates a complete clinical disaster.
Really? Just one space too high?
Yes. When V1 and V2 are placed too high on the chest wall, they look at the outflow tract of the right ventricle from an abnormal superior angle.
And what does that do to the paper?
This artificial angle writes a pattern on the paper that perfectly mimics a lethal anterior wall myocardial infarction.
Oh, wow. So you think they're having a massive heart attack?
Exactly. Or, even more frighteningly, it mimics a rare genetic condition called Brugada syndrome, which we will definitely discuss later.
That is terrifying.
You could end up sounding the alarm, waking up the interventional cardiologist at 2 a.m., and rushing a perfectly healthy patient to the cath lab for an invasive procedure. All because a sticker was placed an inch above where it belonged.
Which proves exactly why the foundation is not just academic trivia. You have to know the mechanics to trust the output.
Absolutely.
Now, these 12 cameras are grouped by the specific muscular territories they watch, which correspond to the coronary arteries feeding those territories.
Yes, and we group them systematically. Leads 2, 3, and AVF sit at the bottom, looking up at the inferior wall of the heart.
Okay, inferior wall.
Then leads 1, AVL, V5, and V6 look at the lateral wall, the left side. V1 and V2 sit right over the septum, the dividing wall between the right and left ventricles. And V3 and V4 watch the massive anterior wall of the left ventricle.
So internalizing this geography now is vital. When we discuss acute infarctions in Part 5, this mapping is exactly how you will identify which specific coronary artery is occluded.
Exactly, it's a map.
Okay, the cameras are set. Anatomy is mapped. Let us talk about the paper itself. The grid.
the famous pink grid.
Because if this pink grid is our ruler, we have to understand the mathematics behind it. The standard paper speed running through the machine is 25 millimeters per second.
Correct.
Because of that speed, the geometry of the paper gives us fixed intervals of time. One tiny millimeter box on the horizontal axis represents 0.04 seconds.
Right, and 5 of those tiny boxes make up one large, heavily outlined box, which represents 0.20 seconds.
And vertically, the grid measures voltage, or the strength of the electrical signal. The standard calibration, or gain, is 10 millimeters, which is 2 large boxes for every 1 millivolt of electricity.
We all learned those numbers in our very first physiology postings. 25 millimeters per second, 10 millimeters per millivolt.
We do. But there is a massive trap here, isn't there?
There is, and it is the very first thing a systematic reader checks.
Before looking at the waves.
Before you interpret a single wave, before you calculate the rate, you must look at the calibration mark. It is usually printed at the very left edge or the bottom corner of the paper.
What does it look like?
It should look like a squared-off rectangle that is exactly 2 large boxes, tall and slightly wide.
Why does that rectangle matter so much in an emergency?
Because machines get bumped, dials get turned accidentally. If the machine is inadvertently set to run at double speed, 50 millimeters per second, the paper moves faster beneath the stylus.
And what happens to the drawing?
Every single wave gets stretched out horizontally. A perfectly normal, narrow QRS complex suddenly looks incredibly wide.
Oh, I see.
You might look at that and misdiagnose a lethal ventricular rhythm. Or, if the voltage gain is accidentally halved to 5 millimeters per millivolt, massive voltage from a hypertrophied heart will look completely normal.
Because it's drawn half as tall.
Exactly. You cannot trust a single measurement on that paper until you verify that the ruler itself has not been altered. Check the calibration mark first. Always.
Verify the ruler. That is a brilliant protocol. Okay, so calibration is confirmed. Our ruler is accurate. Next up. Calculating the heart rate.
Yes, the rate.
Now, the algorithms print a heart rate at the top of the page, but we already established we are verifying everything. How do we calculate the rate manually and accurately?
There are 3 distinct methods depending on the clinical scenario. Let us start with the most common, the 300 rule.
Okay, the 300 rule.
The 300 rule is beautifully efficient, but it comes with a strict condition. It is only for rhythms that are perfectly regular.
Only regular rhythms.
Yes, you simply take the number 300 and divide it by the number of large boxes between 2 consecutive R waves.
And the R waves are those tall, sharp, upward spikes of the ventricular contraction, right?
Exactly. The math is simple. If there is 1 large box between beats, the rate is 300. 2 large boxes, 150. 3 boxes, 100. 4 boxes, 75. 5 boxes, 60.
You just count the boxes and do the division.
It is rapid, visual, and highly reliable for regular rhythms.
I think of the 300 rule like a wide-angle lens. It gives you a great immediate overview. But what if you are in the intensive care unit and you are titrating a highly specific drug and you need to know if the rate is exactly 82 or exactly 88?
The 300 rule is too blunt for that.
Right. So what do we use?
In that scenario, you switch to the magnifying glass, the 1500 rule.
The 1500 rule. How does that work?
It operates on the exact same logic, but instead of counting the large boxes, you count the small boxes between the R waves.
Because there are 1500 small boxes in 1 minute of paper.
Exactly. You divide 1500 by the number of small boxes. So if you count 17 small boxes between 2 beats, 1500 divided by 17 gives you a very precise granular rate of about 88 beats per minute.
But both of those rules, the 300 rule and the 1500 rule, rely on measuring the gap between just 2 beats. That introduces a major vulnerability, doesn't it?
It certainly does.
What if the patient is in atrial fibrillation? What if the rhythm is entirely chaotic and the heart is bouncing around? You cannot use the space between just 2 beats because the next 2 beats might have a completely different gap.
Exactly. When the rhythm is irregular, the 300 rule and the 1500 rule will outright lie to you.
So what's the third method?
For chaotic rhythms, you must use the 6-second rule. This requires zooming out. 30 large boxes on the standard ECG paper equal exactly 6 seconds of time.
Okay, 30 boxes.
So you isolate a 30-box strip, count the total number of complete QRS complexes within that strip, and multiply that number by 10.
You just add a 0.
Exactly. That gives you the average true heart rate over a full 60-second minute.
So we have 3 tools for the rate: the 300 rule for speed, the 1500 rule for precision, and the 6-second rule for chaos.
Perfect summary.
We have our calibration and we have our rate. Now we move to rhythm. Everyone in the hospital uses the phrase normal sinus rhythm, almost as a reflex.
They do say it a lot.
But medically speaking, what does it actually take to prove a rhythm is sinus?
It is not a subjective feeling, it is a rigid checklist. To definitively confirm sinus rhythm, you must ask and answer 4 strict physiological questions every single time.
Okay, lay them out for us.
Question 1. Is there a P wave before every single QRS complex? This proves the atria are firing before the ventricles.
Makes sense. Question 2.
Question 2. Is that P wave upright or positive in leads I and 2? This is crucial.
Why leads IN2 specifically?
If it is upright in those leads, it proves the electrical impulse is originating high up in the right atrium, exactly where the anatomical sinoatrial node, the natural pacemaker, lives.
Ah, so it proves the direction.
Right. If the P wave is upside down, the impulse is coming from somewhere else, traveling backward.
Okay, question 3.
Question 3. Is the PR interval constant? This demonstrates a stable, reliable relationship between the top chambers and the bottom chambers.
And the final question?
And question 4. Is the rate between 60 and 100 beats per minute?
So it has to be a normal speed too.
Exactly. If all 4 answers are yes, you have confirmed normal sinus rhythm. If even one answer is no, you are dealing with an arrhythmia, and you must investigate further.
That leaves the final piece of our foundation. I will be honest, this is the concept that always makes medical students and junior doctors sweat a little bit.
Oh, I know exactly what you're going to say. The electrical axis.
Yes, the axis. I remember learning axis as a complicated math problem involving drawing intersecting vectors on a hexaxial reference system.
It can be a nightmare to learn that way.
It felt entirely detached from the actual patient. How do we calculate the axis quickly? And more importantly, why does it matter?
It has gained a reputation for being overly complex, but at the bedside, it really does not have to be. The electrical axis is simply the average net direction that the heart's dip polarization wave is traveling in the frontal plane.
The average direction.
Yes. Think of all the electrical vectors as a swarm of bees. The axis is the general direction the whole swarm is flying.
I love that.
Yeah.
So where should the swarm fly?
In a normal, healthy heart, that swarm flies downward into the patient's left, aiming squarely at the thick, muscular wall of the left ventricle.
Okay, so how do we measure it without the complex math?
To determine this in 5 seconds, you only need to look at the net deflection of the QRS complex in 2 specific leads. Lead I, which looks from the left, and lead AVF, which looks from the bottom.
Ah, this is where the classic thumbs memory hook comes into play, isn't it?
Yes, it is. Hold your thumbs out. If the main deflection of the QRS in lead I is positive pointing up, give a thumbs up with your left hand.
Left hand thumbs up. Got it.
If the QRS in lead AVF is positive pointing up, give a thumbs up with your right hand.
Okay, 2 thumbs up.
Both thumbs up. That means the electricity is flowing normally down and to the left. The axis is normal.
That is so simple. What if it's abnormal?
Well, if lead I is positive thumbs up and AVF is negative thumbs down, your thumbs are pointing away from each other. They are leaving each other.
Leaving each other. So that's left axis deviation.
Exactly. Left axis deviation. Conversely, if lead I is negative thumbs down and AVF is positive thumbs up, your thumbs are pointing toward each other. They are reaching for each other.
Reaching for each other.
Yeah.
Right axis deviation.
Spot on.
Right.
Right axis deviation.
I love the simplicity of the thumbs, but let me push back here a little.
Sure, go ahead.
If I am in a rushing casualty ward, and I have already determined the rate is 90 and the rhythm is perfectly sinus, what is a slightly shifted electrical vector really telling me? Is it just academic trivia, or does it change my clinical management?
Oh, it absolutely changes your management. The axis is an invisible window into structural pathology.
Really? How so?
The electrical vector operates like a physiological tug of war. Electricity is naturally pulled toward areas of extra muscle mass, like ventricular hypertrophy, because there is simply more tissue conducting the signal.
Okay, muscle pulls it.
And conversely, the vector runs away from areas of dead or infarcted tissue, because dead scar tissue cannot conduct electricity.
So it points away from the damage.
Exactly. Let us apply this clinically. Imagine a patient arrives breathless with a sudden onset of chest pain. You check the ECG. The rate is fast sinus tachycardia. The rhythm is sinus.
Pretty standard so far.
But you check the axis and you realize they have a brand new right axis deviation. The electrical vector has suddenly violently swung to the right.
Why would it do that?
What pulls the vector to the right? Massive sudden strain on the right ventricle. In a breathless patient, a sudden right axis shift combined with tachycardia is a massive red flag for an acute pulmonary embolism.
A blood clot in the lungs.
Yes. It creates enormous back pressure on the right side of the heart. The axis just handed you a life-saving clue that the rate and rhythm alone would never have revealed.
That is incredible. The axis is not just math. It is the physical shifting of the heart's burden.
Exactly right.
All right, connecting this all back to the bigger picture, let us return to the 2.0 AM scenario. Our 54-year-old man, sweating, clutching his chest.
Let's apply what we know.
We apply the foundation we just built. We verify the calibration. It is standard. We calculate his rate using the 300 rule because he's regular. There are just over 3 large boxes between his R waves, so his rate is 95.
Perfect.
We check the 4 questions for rhythm. He has upright P waves in IN2, a constant PR interval, and he is under 100 beats per minute. He is in normal sinus rhythm.
And the axis.
Finally, we check the axis. Lead eye is positive, AVF is positive, both thumbs up. The axis is normal.
So the first critical seconds of our read are complete.
The foundation is rock solid. But we still have not addressed why he's having crushing chest pain. We are going to keep him waiting just a little longer. Because to truly see what the myocardium is suffering, we have to look closely at his individual wave morphology, which we will do when we reach part 5.
He'll be okay for a few more minutes.
Right. Let's take a quick pause here and transition into part 2. Okay, we are back. We have our foundation. Now we step into the core of the analysis, part 2, the systematic 10-step read.
This is where we dissect the tracing wave by wave, interval by interval.
We have already executed the first 4 steps of the system in our foundation: calibration, rate, rhythm, and axis.
Right. Now we must finish the journey with steps 5 through 10. And to understand exactly why this strict wave-by-wave order is our ultimate safety net, we need to consider a different clinical presentation.
Right, let us introduce a new patient for this part. You have a 68-year-old woman brought into the clinic. She has experienced her 3rd fainting spell syncope in the last month. She does not have any chest pain. Her blood pressure is excellent. Her oxygen saturation is perfect. The technician runs an ECG, and the automated machine report spits out its conclusion. Normal sinus rhythm. Normal ECG. Unremarkable.
And here is where the algorithmic blind spots are most dangerous.
Because it says she's fine.
We know exactly why machines fail in these scenarios. They excel at measuring the obvious prominent waves, but they completely lack the clinical context to doubt a subtle interval measurement.
Right, they just look at the big spikes.
If we blindly trust that machine report, we assure her she is fine and we send her home. But if we maintain our discipline and read it ourselves, strictly wave by wave, we might uncover the actual reason she's losing consciousness.
So let us maintain that discipline. We execute the system. Steps 1 through 4 are complete and normal. We move to step 5, the P waves.
The electrical voice of the atria.
Right. How do we read the P waves properly?
When evaluating the P wave, you primarily want to look at lead 2.
Lead 2 again.
Because lead 2 sits at the bottom left and looks up toward the SA node, the wave of atrial depolarization travels directly toward it, giving you the clearest, most prominent P wave to analyze.
So we're looking at the shape of it.
Exactly, the morphology. The first half of the P wave represents the right atrium depolarizing, and the second half represents the left atrium.
Okay, so it's a combined wave.
Yes. If the right atrium is enlarged or struggling, perhaps due to chronic lung disease pushing back on the right side of the heart, the first half of the P wave gets abnormally tall and sharply peaked.
What do we call that?
We call that P pulmonale.
P pulmonale. Got it. And what if the left side is struggling?
Conversely, if the left atrium is enlarged, often due to a stiff mitral valve or chronic hypertension, the second half of the P wave is delayed. This creates a broad-notched M-shaped P wave. We call that P mitrale.
M-shaped from mitrale. That's a great way to remember it. So that is step 5.
Right.
Step 6 takes us from the P wave to the PR interval. Physiologically, this interval is essentially the report card for the AV node, isn't it?
That is a perfect way to describe it.
It represents the crucial pause, the delay, between the top chambers contracting and the bottom chambers firing, allowing the ventricles time to fill with blood.
Yes.
And we have a fantastic memory hook for analyzing this interval. The PR interval and the QRS complex share a magical threshold number, don't they?
Yes, 0.12 seconds.
0.12 seconds.
That is one of the most reliable anchors in electrocardiography. A 0.12 seconds translates to exactly 3 small grid boxes. The physiological rule is that the PR interval must be more than 0.12 seconds, but less than 0.20 seconds.
It needs that healthy delay.
It absolutely needs it. But what if you look closely and the PR interval is abnormally short, less than 3 small boxes?
It's a problem.
And immediately after that short PR, the baseline slurs upward into the QRS complex, creating a sluggish ramp we call a delta wave.
If the delay is missing, it means the electrical signal bypassed the AV node altogether.
Exactly. It means the patient was born with an anatomical anomaly, an extra band of conductive muscle tissue connecting the atria directly to the ventricles.
What is that band called?
It is called the bundle of Kent.
Ah, right.
The AV node acts like a bouncer at a club, slowing down the electrical impulses so things do not get chaotic. The bundle of Kent is a VIP backdoor.
I love that analogy, the VIP backdoor.
While the electricity skips the bouncer entirely, resulting in that short PR interval and the slurred delta wave. This represents Wolff-Parkinson-White, or WPW syndrome.
And missing WPW can be catastrophic, right?
Missing the subtle signs of WPW on a resting ECG can be absolutely catastrophic, because if that patient ever goes into atrial fibrillation, the chaotic electrical signals will flood through that VIP back door without any AV nodal regulation.
And that drives the ventricles too fast.
It drives them at lethal speeds, often deteriorating directly into ventricular fibrillation.
The VIP back door. That perfectly explains why the PR interval is so short. So, moving to step 7. The QRS complex. We said the PR and QRS share that magic number of 0.12 seconds.
They do.
But while the PR must be more than 0.12, the QRS complex must be less than 0.12 seconds. It must be sharp and narrow.
The QRS represents the massive ventricles depolarizing. If it is narrow less than 3 small boxes, it proves that the electrical impulse is traveling rapidly down the His-Purkinje system.
What is the His-Purkinje system for those visualizing it?
Think of the Purkinje fibers as a highly insulated fiber optic superhighway designed to deliver the signal to all the ventricular muscle cells almost simultaneously.
So narrow QRS means it's on the superhighway.
Exactly. But if the QRS complex is wide, measuring 0.12 seconds or more, it indicates a major conduction problem. The signal is not using the fiber optic superhighway.
Where is it going then?
Perhaps a bundle branch is blocked by fibrosis or ischemia. Instead, the electrical impulse is forced to travel cell by cell through the regular working myocardium, jumping slowly across gap junctions.
Like taking a dirt road.
It is using a slow, muddy, unpredictable footpath. Therefore, a wide QRS is never normal. It always demands an explanation.
What kind of explanation?
It could be a bundle branch block, a severe electrolyte disturbance like high potassium, or a rhythm originating deep within the ventricular tissue itself.
Step 7 also requires us to evaluate the voltage, the actual height of that QRS complex.
Yes, voltage is key.
Massive voltage, where the spikes are overlapping into the leads above them, points toward left ventricular hypertrophy, right? The heart muscle has physically thickened, usually from years of fighting high blood pressure, generating more electrical force.
That is correct. But low voltage is arguably more terrifying in an emergency context.
Really? Why is tiny voltage worse?
If the QRS complexes are tiny across all leads, it does not necessarily mean the heart is weak. It means there is something physically muffling the electrical signal between the heart muscle and the electrode on the skin.
Muffling it? Like what?
That muffling effect is usually caused by an abnormal accumulation of fluid, fat, or air. If a patient presents with shortness of breath, a fast heart rate, and suddenly low voltage on their ECG, your mind must immediately jump to cardiac tamponade.
Fluid around the heart.
Yes. The pericardial sac surrounding the heart is rapidly filling with fluid or blood, compressing the chambers and muffling the electrical signal. Alternatively, it could signify restrictive diseases like amyloidosis infiltrating the myocardium.
And before we leave step 7, we must scan the QRS for pathological Q waves.
Q waves. Yes.
Small initial downward deflections,
Yeah.
physiological Q waves, are a normal part of septal depolarization. But a deep, wide Q wave.
That is an electrical window into necrotic dead myocardium.
So the tissue is gone.
The electrode is literally looking straight through a scar into the opposing wall of the heart. Pathological Q waves are scars telling the silent stories of old, completed heart attacks.
Which flows perfectly into step 8, the ST segment. This is where everyone's eyes dart first, but our system forces us to wait until step 8.
Exactly. Discipline.
The ST segment represents the brief plateau phase of cellular repolarization. How do we properly, mathematically judge ST elevation instead of just guessing?
You must measure it at a very specific landmark, the J point.
The J point, where's that?
The J point is the exact junction where the chaotic QRS complex ends and the relatively flat ST segment begins. You find the J point and measure its vertical height relative to the isoelectric baseline, typically the TP segment.
Okay, so height is one thing, but the shape matters too, right?
The shape is arguably just as diagnostic. An ST segment that is elevated but has a concave, upward curving shape like a saddle or a smiley face can sometimes be a benign finding.
Like what?
Like early repolarization in a healthy young athlete, or it could indicate generalized pericardial inflammation.
But what's the bad shape?
An ST segment that is elevated with a convex, dome-like, or horizontal shape, often chillingly referred to as a tombstone. That is the classic lethal morphology of an acute transmural myocardial infarction.
Tombstone. That's a grim name.
It is. The cellular potassium is leaking rapidly from dying tissue, creating massive injury currents.
And we cannot ignore ST depression either. We have to look at the slope of the depression.
Yes, the slope tells a story.
If the ST segment slopes upward rapidly after the J point, it might simply be a physiological response to a fast heart rate.
Right, upsloping is often okay.
But horizontal ST depression, or downsloping ST depression, that is the hallmark of significant subendocardial ischemia. The heart muscle is screaming for oxygen, but the cells have not completely died yet.
That brings us to step 9, the T waves. I often refer to the T wave as the moody witness of the ECG.
Moody witness. I like that.
It represents ventricular repolarization, the resetting of the cell membrane, and it is highly sensitive to the biochemical environment.
Give us some examples of its moods.
If the T wave is unusually tall, narrow, and sharply tinted, like a church spire, you must instantly suspect severe hyperkalemia, dangerously high levels of potassium in the blood.
Church spires mean high potassium, got it.
If the T wave is deeply and symmetrically inverted, it can indicate severe myocardial ischemia, massive strain on the ventricles, or even, strangely enough, central nervous system catastrophes.
Like a brain bleed.
Yes, massive intracranial hemorrhages can alter the autonomic tone so much that it inverts the T waves.
Wow, the heart reacting to the brain. We're almost through the gauntlet. Step 10, the QT interval.
The killer interval.
Yes, our sources emphatically call this the killer interval. Why is this specific measurement so perilous, and how do we check it quickly at the bedside when we do not have a digital caliper?
The QT interval encompasses the total duration required for the ventricles to depolarize and then fully repolarize, essentially the time it takes for the heart to fire and completely reset its electrical gradients.
Okay.
The latter part of the T wave represents the relative refractory period.
Right.
This is a highly vulnerable, unstable microsecond in the cardiac cycle. If the QT interval is abnormally prolonged, that vulnerable window is stretched open wider.
So how do we spot it quickly?
The quick visual rule at the bedside is that the QT interval should measure roughly less than half of the total distance between two consecutive R waves.
Okay, less than half the RR interval.
If the end of the T wave visibly stretches past the halfway mark of the RR interval, it is dangerously prolonged.
And what actually happens if that vulnerable window is left open too long?
It invites absolute catastrophe. If an erratic, premature ectopic beat happens to fire and land exactly on that prolonged T wave, a phenomenon known as the R-on-T phenomenon, it triggers a twisting, chaotic electrical cascade.
And what rhythm does that cause?
The heart is thrown into a specific lethal form of polymorphic ventricular tachycardia called torsades de pointe.
Torsades.
The ventricles stop pumping and start quivering. The patient's blood pressure drops to 0. They will faint, seize, and if it does not spontaneously resolve, they will die.
And what causes the QT to prolong in the first place?
Tragically, the culprits prolonging the QT interval are very often the medications we administer.
Wait, really? Our own drugs?
Yes. Common antiemetics, psychotropics, specific antibiotics like fluoroquinolones, or unrecognized electrolyte deficiencies like low magnesium or low potassium.
This brings everything into focus. What does this deep dive mean for our 68-year-old woman who kept fainting? Let us apply the full 10 steps to her unremarkable tracing.
Let's do it.
Steps 1 through 7 were completely normal. The machine algorithms got that right. Narrow QRS, normal axis. Step 8 and 9, normal ST segments and normal T waves.
Everything was fine so far.
But step 10. When we actually stop to eyeball the QT interval, we see the end of the T wave stretching way, way past the halfway mark of the RR interval.
Exactly. When you actually measure it properly and correct for her heart rate, her QTC, the corrected QT interval, was 0.54 seconds.
That is massively, dangerously prolonged.
It is. Why was she fainting? A quick review of her recent chart reveals her primary care physician started her on a new antiemetic for nausea and simultaneously a fluoroquinolone antibiotic for a urinary tract infection last month.
Both of which prolong the QT interval.
Both drugs independently prolong the QT interval. Together, they stretched her vulnerable window wide open. Her fainting spells were not benign syncope. They were short, transient bursts of torsades de pointe.
Oh my goodness.
Her heart was spiraling into a lethal rhythm, and by sheer luck, spontaneously recovering just before she died.
That is absolutely chilling. The machine missed it completely because it just read normal sinus rhythm based on the P waves and the rate.
Machines don't check medication charts.
The takeaway here is profound. The fixed 10-step order is your only safety net. Never trust the machine's summary interpretation. Only use its raw measurements as a starting point.
Exactly.
Because if you skip step 10 because the first 9 looked fine, you send a woman home to die from a prescription you could have easily stopped.
And that is a burden no clinician wants to carry.
Well said. All right, let's take a breath, pause here, and then we will jump into part 3. Okay, we are stepping into part 3, tachyarrhythmias. Narrow, wide, regular, chaotic.
The fast rhythms.
Yes. There is a universal truth in medicine. When a patient's heart is racing at nearly 200 beats per minute, the ambient anxiety in the room spikes instantly. Everyone wants to do something fast.
The instinct to act quickly is natural, but disorganized action is highly dangerous, which is exactly why we have to ground ourselves immediately before analyzing a single wave with question 0.
Question 0. Let us set a new scene to illustrate this. You have a 24-year-old woman in the casualty ward. Her heart rate is screaming at 186 beats per minute.
Okay, very fast.
She complains of intense palpitations. She is visibly anxious, but she is completely awake. Her blood pressure is stable at a 112/74, and her oxygen saturation is 99%.
Good vitals.
An intern standing next to you is nervously holding the defibrillator paddles, asking, should we shock her to reset the rhythm?
And that intern is forgetting question 0.
Which is
the patient hemodynamically stable? This dictates absolutely everything.
how do we define unstable?
If a tachycardic patient is unstable, meaning they are exhibiting profound hypotension, altered mental status indicating brain hypoperfusion, ischemic chest pain, or fluid rapidly backing up into their lungs because the cardiac pump is failing, you do not waste precious minutes staring at the ECG trying to parse out the exact rhythm origin.
You just shock them.
You provide sedation if time allows, and you perform synchronized electrical cardioversion immediately. You shock them. The diagnosis can wait, tissue perfusion cannot.
But returning to our 24-year-old, her blood pressure is rock solid. Her brain is perfusing. She is stable.
So we do not need the paddles yet. We have bought ourselves time to think.
Precisely. And with that time, we deploy the 4-box matrix. We conceptually map out every fast rhythm by asking 2 incredibly simple visual questions.
What are the 2 questions?
Number 1, is the QRS complex narrow or wide? Number 2, is the rhythm perfectly regular or is it irregular? That creates 4 distinct conceptual boxes, and every single tachycardia lives inside one of them.
I love the matrix. It simplifies everything.
Let us unpack the matrix. Box 1, narrow and regular. The QRS complex is under 0.12 seconds, proving the impulse is using the normal His-Purkinje superhighway, and the beats are marching out with perfect spacing.
We essentially have 3 primary suspects in this box.
Who is suspect number 1?
First is sinus tachycardia. The heart is simply beating fast, usually maxing out around 150 beats per minute. You will see a normal P wave before every QRS.
And how do we treat it?
The most critical thing to remember about sinus tachycardia is that
That completes parts 1 and 2. Continue with video 2, tachyarrhythmias and blocks.